Dear colleagues, I'm honored to have the opportunity to give the presentation on pain management in implant industry, which I believe is a crucial subject, especially when treating patients in implantology. And in 1881, the Assembly of the Scandinavian Dental Association passed a resolution that stated that tooth extractions could be performed so rapidly that patients would be able to tolerate the procedure even without anesthesia. Fortunately, today we have, or with the advent of dental local anesthesia, we no longer need to work under such conditions. But many patients from older generations have experienced pain as an intrinsic part of the dental treatment. A study conducted in the 1970s showed that a significant proportion of these patients, 66%, have fear of visiting the dentist, and 1/3 of them reported experiencing severe pain during the dental treatment. And the negative perception or the poor reputation of us, the dentists, may not only be attributed to the pain we cause or the patient's personal negative experience, but also to experiences of the patients, the relatives, and often kind of unfavorable portrayal of the dentist in the media, as you can see on the right side. Even though we now have significantly improved the treatment options, pain remains the most common reason for seeking emergency dental care today. And often this pain even persists for 7 days or longer. There's a nice word in Germany that's called Holzweg, which means that we're wrong. We sometimes mistakenly believe that the satisfaction of our patients is primarily due to our technical experience, which or why it might be surprising to realize that some colleagues who are less technically proficient or who do not really achieve the perfect dental implant placement or the perfect treatment run a more successful business plan than we do. And this discrepancy suggests that something we kind of do not really learn during our academic career, during our training, our studies, like interpersonal skills as respect, friendliness, openness, honesty may be far more important to our patients. And in fact, these skills account for up to 85% of the business success. Another and not really unsurprising factor influencing the patient satisfaction during our treatment is the cost of the treatment and the subject of today's lecture, pain-free treatment. Interestingly, only 15% of our success in the business is attributed to the professional competence of us, the dentists. We conducted a study in Mainz in Germany, asking the dentists around our country which pain medication they most commonly used or prescribed. And the outcome was not really surprising, as 73% of them reported prescribing ibuprofen, which is the most commonly used analgesic in Germany. Additionally, 28% stated that they prescribe acetaminophen and 20% metamizole, which is banned in many countries due to reasons I will explain later on. While the results regarding the acute pain management were kind of really predictable, the responses relating the chronic pain management were less straightforward. We asked our participants what they would do in a case when the patient continued to experience severe pain after any kind of dental treatment for more than 6 weeks, despite being treated with ibuprofen, acetaminophen, metamizole, or even opioids. And most dentists reported that they would just simply continue the same treatment. But this approach is not very consistent with the current guidelines, which is why we have some issues, especially in Germany, but maybe worldwide. One of the primary issues we face in our country is a kind of general uncertainty about the pharmacological treatment of our patients. And this uncertainty revolves around questions like, which analgesic is appropriate for my patient, what risk factors must be considered, and in what dosage should the medication be given in which indication. Secondly, we face a challenge of pain chronification. And when the patient, as in the example, experience prolonged pain lasting, for example, more than 6 weeks, there can be changes in the pain perception system, both peripherally and centrally, which then leads to chronic pain. And this chronic pain is also for us in the University Medical Center very complicated to treat, especially by our specialists. And thirdly, due to the demographic changes, we now see a significantly higher proportion of older patients. While age is not really equal to illness, the older individuals generally have a higher risk of conditions such as cardiovascular disease or diabetes or even respiratory disorders. Therefore, the individualization of the treatment is crucial, especially when we treat patients in higher ages. And then we need to choose an analgesic that aligns with the patient's profile, as not all these analgesics are suitable for every kind of patient. Now, let's examine the analgesic therapy pyramid. And this pyramid was initially developed for chronic pain treatment, but now also adapted for the acute pain treatment. And the foundation always involves the non-opioid analgesics. And if the patient increases the low potency opioids such as tramadol, tilidin in Germany, may be added. If these are insufficient, the collaboration with an anesthesiologist or a pain specialist becomes relevant. And at that point, the low potency opioids are replaced by the higher potency opioids while always maintaining the non-opioid analgesics. And here we categorize our non-opioids into NSAIDs, the non-steroidal anti-inflammatory drugs like ibuprofen, diclofenac, into COX-2 inhibitors, metamizole, and acetaminophen. NSAIDs, also including the COX-2 inhibitors like etocoxib, work by inhibiting the production of prostaglandin H2 via the COX enzymes. And this results in an analgesic effect we really need to use in our implant treatment, an antipyretic effect, and an anti-inflammatory effect, which is very beneficial in our dental treatment, our daily practice. A rather not that beneficial effect is the antiplatelet aggregation, which is typical for like acetylic salicylic acid. And there may be a little higher bleeding risk due to this effect, but there are some more severe side effects we need to consider. These side effects stem from their mechanism of action. By inhibiting the prostaglandin synthesis, they reduce the, for example, protective mucosal layer of the gastrointestinal tract, which may lead to gastritis, duodenitis, and even gastric ulcers. And to minimize this risk, the long-term use of NSAIDs should be avoided. They may also cause fluid retention in the renal system due to a reduced renal blood flow, which may also lead to reversible or even irreversible kidney damage with a prolonged use. And interestingly, there's also a potential link between these NSAIDs and heart damage. And the exact mechanism of action on how these NSAIDs may affect the heart is not fully understood yet, but in healthy individuals, when engaging in physical activities like sport, running, something like this, the intracardiac vessels typically relax and allow an increased blood flow through the heart muscle. And this relaxation method may be inhibited by the NSAIDs, which may impair the proper cardiac blood flow. Here in this list, we see the most commonly used NSAIDs in dentistry and even in general medical practice. And one important consideration is that diclofenac, typical NSAID, which may be used in osseous pain, which is really commonly prescribed in Germany, carries a significantly higher cardiovascular risk due to the metabolic pathway. Since 2013, it has been contraindicated in patients with heart failure, specifically classified as stage 2 to stage 4, according to the New York Heart classification. So in very low stages in heart failure, it is already contraindicated, as well as in coronary heart disease or peripheral arterial disease. And these contraindications are especially relevant for our older patients with a higher risk for such conditions, which should be considered during the dental treatment or the recommendation prescription of any analgesic after implant treatment. And this warning also applies to etocoxib, the COX-2 inhibitor, which is additionally contraindicated in individuals under 16 years of age. In this figure, we can observe that more does not necessarily mean better. The graph shows different dosages of ibuprofen and acetaminophen and the correlation to the pain intensity after a surgical intervention. And we see that the average pain intensity in the placebo patients are around 4 to 6 average pain. And in yellow, you can see the curve for ibuprofen 400 milligrams. This dosages pain-reducing effect up to 2 hours, and the effect then gradually diminishes over 5 to 6 hours. But interestingly, if we look at the green and iliac curves representing ibuprofen 6 and 800 milligrams, they are almost identical. Both dosages produce the same pain-reducing effect and follow the same pattern of diminishing the efficacy. And this indicates that there is no significant difference between ibuprofen 6 and 800 regarding the analgesic effect. This ultimately leads us to challenge the common belief that higher dosages automatically result in a better pain relief. This phenomenon is called a ceiling effect. Once a maximum effect is reached, increasing the dosage does not enhance the therapeutic outcome, but only raises the risk of any kind of side effect. For ibuprofen, the optimal dosage for the maximum pain relieving effect is 600 milligrams and not 800 milligrams. And the higher 800 milligrams only possesses a greater risk for side effects such as gastritis, duodenitis, gastric ulcers, and potential kidney failure in the end. On the next slide, we discuss acetaminophen. And unlike the NSAIDs, the acetaminophen does not exhibit any anti-inflammatory effect, which is beneficial in our, especially the larger implant cases, but also no antiplatelet effect. The recommended dosages ranges from 500 to 1000 milligrams per administration with a maximum dose of 4 grams per day. And one critical aspect to consider is here the hepatotoxicity. It significantly differentiates acetaminophen from other NSAIDs. And while the NSAIDs typically cause side effects like kidney failure after a prolonged use, acetaminophen can cause acute liver failure if the maximum dosage is exceeded, particularly in those patients with pre-existing liver diseases such as liver cirrhosis, especially in combination with malnutrition or alcohol consumption. Therefore, in such cases, the dosage should be reduced or, if possible, even avoided altogether. A lesser known fact is that, similar to the NSAIDs, long-term use of acetaminophen may also lead to gastrointestinal and cardiovascular side effects, but this is generally less pronounced and less known than those associated with the NSAIDs. Now we come to metamizole, a pain medication that is really frequently used in Germany, but banned in several other countries due to some severe side effects. Metamizole itself is analgesic, antipyretic, and spasmolytic, and this spasmolytic property makes it particularly useful in cases such as gastrointestinal problems or conditions like kidney stones. One of the most critical aspects of metamizole is the potential cause of severe side effects, like achronocytosis, which is a reduction of granulocytes in the blood, but not only granulocytes, also other immune cells, erythrocytes, thrombocytes, and this can not only result in severe illness, but also in some cases, even death. While the hepatotoxicity has been reported with metamizole use, but is not as common and acute as with acetaminophen. And unlike like allergies that occur during the first exposure, the side effects of metamizole can appear unpredictably, even if the patient had no previous issues with the medication. It can happen during the first use, after a week of use, or even after a prolonged intake. And it's kind of really unpredictable and can happen every time. And due to this risk of achronocytosis or even death, the regulatory bodies in Germany have stated that metamizole should only be used for severe pain, particularly after injuries or surgeries or tumor pain, and not for dental procedures that typically cause mild or moderate pain. And it is especially contraindicated when other medications have not been tried before. And this is especially important for legal safety yeah, for legal safety and the safety of the healthcare provider. We have to bear in mind that the proper patient communication is crucial when prescribing metamizole. Also with other pain medications, but especially for metamizole due to the severe side effects. First of all, it is important to inform the patient about the risk of the agranulocytosis and the potential severe side effects. But that is not as important as the next point. The safety information. The patient should be educated on recognizing the symptoms of the agranulocytosis, which are very non-specific, as you can see here. It's like fever, sore throat, inflammatory mucosal lesions. And if these symptoms occur, and the patient has to know this, the patient should seek the medical attention immediately, discontinue the metamizole use, and inform the healthcare provider about the medication use. And last but not least, we all know it, the thorough documentation of all these communications and the patient consent is crucial for medical legal protection. The importance of this documentation is underscored by the increasing number of legal cases related to medical malpractice in Germany. We here see data from 2022 showing around 13,000 cases of potential treatment errors across all medical specialties, with 1/3 confirmed mistakes. Dentistry only accounts for 7.7% of all these cases of medical malpractice, which is not very insignificant given the lower number of dentists compared to all other medical professionals. In general dentistry, we have 861 cases of malpractice, maxillofacial surgery, 134 cases, and orthodontics or surgery, much lower numbers. And the most frequent errors across all medical fields, you have to imagine all medical fields like orthopedics, gastrointestinal surgery, every kind of medical field. And here we see the kind of faulty procedure. And dentistry here is in the top 3 of all faulty procedures, with the root canal treatment, place 4 with the dental prosthesis, place 7, tooth extraction, place 13, tooth restoration with filling, and place 16, the surgical tooth extraction. We now come back to metamizole, and while the documentation errors itself are kind of very rare with 1.9% of cases, there are also other factors that can be summed up as documentation errors en gros as well. We have one point that is documentation also includes the diagnosis of any allergy or contraindication against the use of metamizole, like MTX use or some blood cancer types, as well as the organization, communication, the information of the patient about the side effects and how to proceed if they occur, and the documentation itself, which accounts for 28.1% of mistakes or errors that occur during the subject of documentation and medication use. And here we see the timeline for analgesia, which begins with the sedation or anxiolysis with very anxious patients or in longer procedures, followed by the so-called preemptive analgesia, administered 30 to 60 minutes before the dental procedure. alongside with the local anesthesia. And finally, we have the post-operative analgesia. We start with the preemptive analgesia, a concept first described in 1913 by George Washington Cryle. He discovered that the administration of local anesthesia in the surgical area, as we always do in awake patients, during the intubation anesthesia, resulted in better cardiovascular stability during the surgery. And this makes totally sense because during the intubation anesthesia, the patient does not consciously perceive the pain, but the pain still originates in the surgical area. And in this situation, the inflammatory substances like substance P, TNF alpha, and so on are still present in the tissue and transmitted to the spinal cord, even though the brain does not register the pain. And based on this observation, George Washington Cryle expanded the concept of what is now known as balanced anesthesia, which combines not only the local anesthesia with the intubation anesthesia or sedation, but also the combination of local anesthesia with pain medication with the sedation to eliminate all sources of pain. And the rationale behind this approach is that pain, and I think we kind of all experience this, is usually most intense immediately after the surgery, when the effect of the intubation anesthesia wears off and the inflammatory mediators in the tissue remain active and cause the pain. The goal in the end is to prevent the central sensitization process where the gene expression lowers the threshold of the pain transmission to the brain, making it easier for the pain to develop and persist. And this principle can also be applied to dental medicine. In general surgery, we see here a systematic reviews including 45 studies. It has been shown that the preemptive analgesia using NSAIDs 30 to 60 minutes before surgery, so one pill 30 to 60 minutes before the surgery, like ibuprofen or any other, can significantly reduce the acute postoperative pain. We see here a forest plot in the middle, the zero line, where should be no effect. On the left, all studies showing reduction in acute postoperative pain after the administration of preemptive analgesia. And this little part in the graph shows the summary of all studies showing a significant reduction in acute postoperative pain when preemptive analgesia is used. But not only acute postoperative pain, also the late postoperative pain is reduced, as well as the required morphine dosage after surgery and the time until the next pain medication is necessary. But we have a problem. We have here all surgical procedures summarized, and how does this apply to dental medicine? I have a good information. This positive outcome is not limited to general surgery, but also applies to our implantological treatment. Here we have a systematic review involving 31 studies, 2,000 patients, demonstrating very similar results, particularly in wisdom tooth extractions. The forest plot shows a significant reduction in pain after the surgery, acute and late postoperative pain, and a reduction in medication intake when the preemptive analgesia is used. But there is a potential issue regarding the off-label use of this medication. And now we have to first define the proper use of a medication, which is typically defined by the manufacturer or the manufacturer's product information, which says like the treatment of pain. And if the medication is used outside this specified indication, it is called off-label use. And if side effects occur, the liability shifts from the manufacturer to the prescribing physician. This creates a higher risk for us, the healthcare provider who prescribes such analgesics outside the manufacturer's product information. Fortunately, in 2021, an expert statement in Germany clarified that the perioperative use of non-opioids, especially the pre, intra, and post-operative use of these analgesics, does not constitute a classical off-label use and should therefore be part of a multimodal perioperative analgesia concept, which is definitely recommended to reduce the pain of the patient. Regarding the analgesics, which can be used in general surgery, the standard options include various NSAIDs, COX-2 inhibitors, and in dental medicine, the choices are a little bit more limited. Diclofenac, while very effective in a narrow indication range, is contraindicated in several cardiovascular risk patients, as we have seen before. Itracoxib, similarly, is only indicated for a maximum of 3 consecutive days in dental practice, but also recently gained the approval for treatment of toothache. And the most commonly prescribed analgesic in dentistry remains ibuprofen. One advantage of itracoxib is the long duration of the action, lasting up to 24 hours, which means that the patients only need to take 1 dose per day. But it is very important to remember that itracoxib is still an NSAID and is similar to the other NSAIDs. We should never combine those NSAIDs with COX-2 inhibitors. They act very similar. If the analgesic effect is insufficient, the patient has already taken the itracoxib, it is inappropriate to administer another NSAID, and then we have to use acetaminophen, for example, which is an alternative, an NSAID. But what's the evidence in preemptive analgesia in the context of dental implantology? And here is a very interesting study from 2023, where the colleagues assessed the effect of different analgesics, such as itracoxib, acetaminophen, ibuprofen, in the context of preemptive analgesia in dental implantology. And the study showed that, or the comparison of pain scores, as you can see here, after the local anesthesia. The placebo is represented in red. We see an elevation of the pain score up to 12 hours and pain that persists up to 48 hours. And then we see here acetaminophen shown in the iliac line with the lowest pain-reducing effect compared to the other medications. Ibuprofen, depicted in the blue line, showed a good analgesic effect lasting up to 12 hours. But interestingly, at that point, the effects of the medications start to be different. Itracoxib marked in orange demonstrate the highest pain-reducing effect and the longest duration of actions, with the patients not experiencing any pain after surgery. And at the 24-hour mark, pain was absent in all groups except the placebo group, where pain lasted up to 48 hours. So the worst thing we can do is not give any preemptive analgesia because the pain persists for such a longer time period. Summed up, we have acetaminophen with the lowest pain-reducing effect and itracoxib with the best analgesic efficacy in implantology. However, there are still limited studies on the effect of preemptive analgesia, specifically in implantology, and there is only one systematic review, including 2 studies, and this one study showing an effect in a prospective controlled study. So now I would like to move to a concept that I called preemptive analgesia plus. This involves adding corticosteroids to the regimen. Corticosteroids have a similar mechanism of action, as you can see here in the picture, to NSAIDs, but act a little bit earlier in the inflammatory cascade by inhibiting the phospholipase, reducing the production of prostaglandins and leukotrienes. And this leads to 2 main effects. First of all, the fast-acting anti-inflammatory response by inhibiting the phospholipase and a slower, more prolonged anti-inflammatory effect by modulating the gene expression through the glucocorticoid receptor, which is very interesting. So we have a short and a long-lasting effect in glucocorticoids after a single use. Side effects from corticosteroids typically occur after a long-term use, such as gastric ulcers, endocrine disorders, but with a single or short-term use, the risk of side effect is very minimal, which is good for us. Several studies support the benefit of using corticosteroids as an adjunct to the preemptive analgesia or the analgesia itself. And we have a systematic review analyzing the combination of diclofenac and dexamethasone in wisdom tooth extraction, which demonstrates a significant reduction in pain intensity and swelling. One of the most notable studies conducted by Moore and colleagues in 2005, and they examined the effect of combining rofecoxib, similar to itracoxib, with dexamethasone compared to using each medication alone and compared to the placebo. In the placebo group, here we have a table. In the placebo group, the time to first analgesic intake was around 3.3 hours with an average pain score of 6 out of 10, which is quite high for dental procedures, in my opinion. The corticosteroid alone delayed the first analgesic intake just a little bit, but still resulted in relatively high pain scores of 5 out of 10. The analgesic alone delayed the need for an additional pain medication around 5 hours, but still the pain score afterwards was 5 out of 10, still kind of very high. The surprising and crucial finding was that the combination of an analgesic with the corticosteroid significantly improved the pain control. Here we have the time to first analgesic intake was significantly longer. Here, 5.6 hours, and the pain at this time was much lower compared to the other kind of medication. So the combination of a corticosteroid and analgesic resulted in a 40% reduction of pain. Additionally, this study also looked in trismus following third molar extraction, and the placebo group showed a high incidence of trismus lasting 3 to 7 days after the surgery, which is quite long in my opinion. Analgesics alone had a moderate effect, reducing the trismus, while the corticosteroids alone showed a more pronounced effect, but still the combination of an analgesic with the corticosteroid resulted in a 56% reduction in trismus, which is significantly more effective than either treatment alone. And this evidence strongly supports the combined use of an analgesic and the corticosteroids for better pain management and the reduction of postoperative pain and postoperative complications, especially in the context of dental surgery. Now we move to the postoperative analgesia. Here we have a list of the most commonly used analgesics in both general and dental medicine. On the right side, you see the so-called number needed to treat, which indicates how many patients we need to treat with a substance so that one patient experience 50% less pain. So the lower the number, the better the analgesic effect of the medication. That's easier. First of all, paracetamol has the lowest analgesic effect among the commonly used analgesics. Surprisingly, metamizole 500 milligrams also showed a relatively low effect with a number needed to treat of 2.4, raising the question whether the risks are adjustable given the availability of better alternatives. These data come from third molar extraction studies, making them directly applicable to dental practice and implantology. Ibuprofen 400 milligrams shows a comparable number needed to treat to metamizole, while etocoxib has, as seen earlier in the preemptive analgesia, has the best number needed to treat with 1.7, but only at a higher dose. Etocoxib is particularly advantageous because it is taken only once daily with paracetamol as rescue analgesia, as I have already explained. But the best analgesic regimen is, as you can see here, the combination of very low doses, 200 milligrams of ibuprofen, combined with 500 milligrams of acetaminophen, which outperforms both higher dosages of any single agents or etocoxib. And this combination is now also highly recommended due to the superior efficacy by our current guidelines. When comparing these combinations of opioid or these combinations to opioid analgesics, such as tramadol 100 milligrams, the number needed to treat is significantly higher. So the pain-reducing effect worse with a number needed to treat of 4.6. And even the combination of 1 gram of acetaminophen with oxycodone, a potent opioid, is less effective than the low dose of ibuprofen and acetaminophen. This finding is supported by the 2021 guideline, as already said, on acute postoperative and post-traumatic pain, which recommends NSAIDs, COX-2 inhibitors, metamizole as the first choice over the less effective acetaminophen. And the guideline specifically highlights the efficacy of the low-dose combination of ibuprofen and acetaminophen, which in my opinion, emphasizes the superior efficacy of this medication, the lower risk profile, and the suitability as an alternative to higher doses of the monotherapy. This meta-analysis here includes 82 randomized controlled clinical trials on tooth extractions, which confirms that the combination of low-dose ibuprofen and acetaminophen provides the most significant pain relief here 6 hours post-surgery. And this combination, and I'm very happy to say this, is now in Germany widely available over the counter, marked under names like Sinophen, Ibohexal Plus, due to the proven effectiveness and safety and the recommendation in the German guidelines. Now, let's discuss the ideal concept in dentistry and implantology regarding the analgesic treatment. And for minor pain, such as a single implant insertion, for example, ibuprofen or acetaminophen in low doses can be recommended as needed. It's completely sufficient. For the mild or moderate pain, a strict dosing interval of ibuprofen or the combination of ibuprofen, acetaminophen every 6 hours over 24 hours is recommended to prevent the pain onset. And after 24 hours, the patients can take ibuprofen or acetaminophen every 4 to 6 hours as needed. In cases of moderate pain, such as large augmentation, sinus lift, shell technique, or maybe a full arch implant placement, the combination of ibuprofen and acetaminophen every 6 hours for 24 to 48 hours is advised to completely block the pain development. And after this period, either the combination, like the low-dose combination, ibuprofen 200, acetaminophen 500, or a single analgesic can be used as needed. And the pain, as we have already seen in the studies before, usually decreases significantly after 24 to 48 hours. And during the surgery, the use of corticosteroids is beneficial, so preemptive analgesia plus, is beneficial for both pain and swelling after the surgery. And due to the short-term application, the side effects are minimal or kind of non-existent. And in cases of expected significant swelling, like with a larger augmentation, the corticosteroids can even be continued for 1 to 2 days, like dexamethasone at dosages of 4 to 8 milligrams, which should be taken in the morning. That's very important to avoid disrupting the sleep-wake cycle. And lastly, for patients with severe pain or those who have not responded to standard pain medication, we follow the WHO pain ladder. And this involves the combination of, as we have already seen, the non-opioids, ibuprofen plus acetaminophen, with a low to medium potency opioid like tilidine or tramadol every 6 hours for 24 to 48 hours again. And after this period, again, the patient can continue the medication as needed to prevent the pain and chronification especially. This structured approach helps manage the pain effectively while minimizing the side effects. Now let's address the topic of opioids. One important aspect to consider is the risk of addiction and the regulations surrounding the opioid prescriptions. And according to the German guideline for the treatment of acute and post-operative pain from 2021, it is recommended that opioids be administered in the combination with non-opioids for moderate to severe pain to minimize the opioid use in the end, which is very crucial in my opinion. And in Germany, there are very specific regulations that state that the classification of the active substance of this low potency opioids under the narcotic regulations is not scientifically justifiable when it comes to certain opioids like tramadol and tilidine, especially when these are combined with the antagonist that reduces the potential of addiction. Compared to stronger opioids, the addiction potential of tramadol and tilidine, particularly when combined with the antagonist, is considered low. And this regulation allows us as dentists to prescribe tilidine at doses of up to 300 milligrams, which is quite high for dental patients, but only in combination with the antagonist naloxone to prevent any kind of addiction. And the same applies for tramadol. So that was a brief overview of the analgesic regimen we recommend at the University Medical Center Mainz. To summarize, we begin with the sedation anxiolysis in patients who are particularly anxious or stressed, or when planning a longer surgical procedure like the large augmentations. Then we proceed with the preemptive analgesia, 30 to 60 minutes before the surgery, using, for example, ibuprofen 600 milligrams or etocoxib 60 to 90 milligrams. And this helps reduce intra and postoperative pain and decreases the need for additional analgesics after the surgery. Local anesthesia is then administered following a gentle surgical procedure. Postoperatively, we adapt the analgesic regimen based on the pain level of the patient. For mild pain, we prescribe medications as needed. For moderate pain, we recommend administering analgesics at fixed intervals of for 24 to 48 hours, ideally combining ibuprofen and acetaminophen if there are no contraindications. And in cases of severe pain, we follow the WHO scheme, combining the non-opioids with the low potency opioids like tramadol, tilidine. And this is crucial to use a combined treatment approach, utilizing all the available options alongside this timeline. Additionally, it is important to incorporate the latest advancements, including the combination of analgesics with corticosteroids during and after the surgery to enhance the pain control and minimize the swelling. Thank you very much for your attention, and I would like to highlight a book that I co-authored with my senior consultant at the University Medical Center Mainz. It is titled Pain Control in Dental Medicine with local anesthesia, analgesia, and sedation, and currently it is available in Germany, but we're definitely planning to release an English edition soon, and I truly appreciate your attention, and I'm looking forward to any questions you may have. Thank you very much. Thank you everyone for your attention, and I got a lot of questions. I will go through them now. Got the question if NSAIDs affect the osseointegration of implants, and how do they affect the post-op inflammatory reaction needed for osseointegration? And the clear answer is a yes and a no. NSAIDs can potentially affect the osseointegration of dental implants because they inhibit the prostaglandin synthesis, as I already said. And this plays a crucial role in bone healing. And this could be a biological mechanism for impaired osseointegration, but the actual impact may vary depending on the NSAID, on the dose, on the duration, patient-specific factors, and their is no clear evidence on showing any impact on osseointegration at all. Therefore, you should not give pain medications for a longer period of time, especially immediately before implant placement or augmentation and after that. But in generally, it is anticipated that for short-term use, it's safe. So the second question, is the preemptive use of corticosteroids recommended in implant or wisdom tooth surgery? And based on the current evidence, the preemptive or intraoperative administration of corticosteroids, especially when combined with analgesics, has already shown, as I demonstrated, clear benefits regarding the pain and swelling after the surgery, after wisdom tooth removal. In my opinion, these data suggest that especially a single dose corticosteroid injection intravenously or orally with 8 milligrams of dexamethasone can also be advantageous in implant surgery, especially in the more extensive procedures such as sinus lift, full arch rehabilitation, the augmentations, GBR, and so on. And the risk of side effects is very minimal due to the short-term use, especially when you just use it once immediately before or during the surgery. So there are no data showing anything in implant surgery, but the data on wisdom tooth removal are very good for the use of corticosteroids. Third question, is there a synergistic approach in analgesia, such as combining different analgesics or using analgesics with other medications to enhance pain control and reduce the side effects? And I think the question meant the use in preemptive analgesia. I at least hope so. And when it comes to preemptive analgesia, there is currently very limited evidence regarding the combination of different analgesics as in the post-operative treatment, for example, with ibuprofen and acetaminophen. But when we look at the well-documented benefits of the multimodal analgesia in the post-operative care, I believe that the combination of ibuprofen and acetaminophen preemptively could offer very similar advantages, and such as improved analgesic efficacy, fewer side effects compared to the higher single dose analgesic. We will see in the future. We still need some studies concerning this, especially in implant dentistry, but I'm looking forward to have them in the future. So, fourth question. There's a combination of ibuprofen and acetaminophen on the market now, but according to the manufacturers, it's only indicated for patients over 18 years of age. Would you recommend to prescribe the two products separately in younger patients? And this is indeed correct. It's only recommended for grown-ups, and if we perform larger surgery in younger patients, like 14 to 18 years old, we need to bear in mind that there's a maximum dose for those younger patients. Sometimes it's weight adapted, sometimes it's according to the age of the patient, and I think the combination of ibuprofen 200 milligrams and maybe acetaminophen at 500 milligrams in lower maximum doses is beneficial in younger patients as well, even though the combination or the combined product is not recommended to prescribe in these younger patients, or not according to the manufacturer's regulations. But if there's a larger surgery in such younger patients, I would say yes, it's there are some benefits in those younger patients. So, number 5, how many times a day do we prescribe the combination of ibuprofen 200 milligrams and acetaminophen 500 milligrams? And we just need to bear in mind that there is a maximum dose for acetaminophen of 4,000 milligrams a day. It's 8 tablets, and for ibuprofen, it's in general 1,200 up to 2,400, so 6 to 12 tablets per day. In general, we prescribe it on demand or in a fixed dose up to six times a day, and this is according to our patients, it's completely sufficient. It's completely fine. And then we have the lower dose per day in both products, ibuprofen, acetaminophen, a lower dose per day. And in the end, this is the reason why we have less side effects after the administration of the combination of both products compared to the higher single dose of any product each, and a better pain reducing effect. So next question, there are a lot of questions. Is it safe to give a single dose of 8 milligrams of dexamethasone, or are you giving lower dosages in the preceding days? It is, according to the current literature, it's safe to give 8 milligrams of dexamethasone preoperatively or intraoperatively, and in most cases that's totally fine for reducing the swelling and the pain after surgery. And if you expect much more pain and or swelling, like in wisdom tooth removal, if you remove all 4 wisdom teeth, or if you do larger augmentations, sinus lift, full arch rehabilitation, something like this, you can prescribe it afterwards, but I would prescribe it in a lower dose, like 4 milligrams for up to 2 days. And we do not do anything more in our larger surgeries at the clinic, like in fracture patients or patients with a surgery of the upper and lower jaw. It's totally fine. What about diclofenac as an analgesic and anti-inflammatory? Is it effective? Yes, it's an NSAID. It's effective, but we still need to bear in mind that it's contraindicated in a lot of patients with cardiovascular risk factors, such as cardiac insufficiency or peripheral arterial disease. So it's totally fine to prescribe diclofenac, especially when you have osseous pain, such as like arthritis, or after injuring the bone after fractures, for example. It said it's sometimes a little bit better for the osseous pain, but we still need to bear in mind the contraindications in these cases, and especially in older patients. There are a lot of patients where the analgesics are contraindicated. Any experience of local injection of 2 milligrams of dexamethasone buccal into the oral mucosa? And there are some studies, indeed, there are some studies showing that the injection locally, especially near the second molar, is effective in reducing swelling, trismus, improving the recovery after dental surgery. The dose was in most cases 4 milligrams, and I have found 3 studies showing improved improved swelling and trismus after that. But we still need to bear in mind that the systemic administration of dexamethasone, like orally, intravenously, intraoperatively, this leads to a reduction of the prostaglandin synthesis and has a short and a long-term effect in the whole body, which is, in my opinion, a little bit more beneficial compared to the local administration, especially when you perform surgery in different areas of the jaw. So, isn't it recommended to give a corticosteroid with NSAIDs? If yes, in which cases? Isn't it better for swelling than the ibuprofen acetaminophen combination? Yes, it is recommended to combine the corticosteroid with the NSAID, as already said, and we can, in the future, there are no studies, but we can think about giving the combination of ibuprofen and acetaminophen and combine that with the corticosteroid, because all these agents act a little bit different and we inhibit the production of the inflammatory markers and the pain markers within the tissue locally. Is it allowed in Germany to the painkiller to give it in the hand before leaving the clinic? It's not legal to give the patient free pain meds. They're still sometimes available over the counter, like the combination of ibuprofen and acetaminophen, which is quite beneficial regarding the prescription orders. But it's not legal to give the patient some pain meds as a doctor, but we're free to recommend it or prescribe it. So I'm searching for some questions I didn't already answer. How many days can we prescribe pain medication? That's an interesting question, because the longer we prescribe the pain medication, the longer the patient takes the pain medication, the higher is the risk for side effects, as I explained in the sections with NSAIDs, acetaminophen, metamizole, something like this. And in acetaminophen, it's the risk for acute side effects like hepatotoxicity is much higher. So the longer term administration has not such a high risk for any severe side effects compared to ibuprofen, for example. There's no threshold like 1 week, 2 weeks, 3 weeks. There are some patients with certain risk factors for gastric ulcers, for example. These are patients like that take corticosteroids for a longer time period, patients, men aged over 65 years, women aged over 75 years, patients taking anticoagulants or antiplatelet agents, or patients who have had gastric ulcers before. I would not recommend to give them pain meds, especially NSAIDs, for a longer period of time. I think in most cases we have already seen that the pain scale drops at 24 to 48 hours. So that's the average time patients need pain meds. And after that, maybe 1, maybe 2 times daily with a very lower dose in total. But I would not recommend to prescribe or recommend the NSAIDs for longer than 1 or 2 weeks because of the high risk for side effects after that. Does the usage of corticosteroids may delay the healing process? According to the data we have for NSAIDs, the corticosteroids also inhibit the production of prostaglandin. So maybe, we don't know, but in contrast to the pain meds, we prescribe corticosteroids just once or maybe for 2 consecutive days afterwards. So there might be maybe a little effect, probably no effect on the healing process at all. I think maybe it is indeed more beneficial because when we reduce the swelling, the blood flow within the tissue is much better, and this leads to a better healing in the end. Any specific medication in case of patients having diabetes and having been treated with implant surgery. So diabetes is no risk factor for any pain med at all, but we have to bear in mind that patients who have diabetes have a higher risk for cardiovascular diseases, and so or for renal diseases, kidney disorders. So NSAIDs may not be the best option for patients with long-term diabetes or with not really well-controlled diabetes with an HbA1c of larger than 8%, something like this. And patients who do not go to the doctor to let their diabetes be treated well, who do not control the blood sugar regularly, maybe not the ideal patients for implant surgery at all, because in diabetes we have a much higher risk for implant failure, especially when not controlled. So maybe be a little bit careful with the NSAIDs and the COX-2 inhibitors. Acetaminophen should be completely safe in those patients. A little bit out of the subject, what are the recommendations for usage of the amount of adrenaline with local anesthesia? Is there a interference with any painkiller? No, indeed, there are some studies showing that the preemptive analgesia with ibuprofen, hydroxy whatsoever leads to a better local anesthesia. The patients have less injection pain. They experience less pain during the surgery, especially in patients with inflammation inside the tissue. So the preemptive analgesia itself will improve the effectiveness of the local anesthesia. And regarding the subject adrenaline within the local anesthesia, there are a lot of studies, especially from Professor Daublander from the University Medical Center of Mainz, who did a lot of studies concerning that subject. Found out that we use articaine in Germany. It's in most cases used. And if we do use articaine, we combine it with adrenaline in a combination of 1 to 200,000, not the 1 to 100,000, because the higher concentration of the adrenaline within the local anesthesia leads to a higher, especially in the patients with cardiovascular risks, leads to a much higher complication rate. So we try to avoid this. Can ibuprofen be used in patients with gastric ulcers? Yes, but be cautious. For short-term use, it's fine. If the patients have or has active gastric ulcers, then no, clearly no, contraindicated. But if the patient have had a gastric ulcer in the past, you can use ibuprofen, but you have to combine it with I don't know how it's called in English. It's pantoprazole for us, so to protect the gastric system from the acidicity. Is itracoxib 120 milligrams plus acetaminophen 500 milligrams, or does it provide better effect than ibuprofen 400 plus acetaminophen? Considering minor oral surgeries such as removal of wisdom teeth or implant surgery, there are no studies showing anything like this. I think itracoxib 120 milligrams is a really high dose. In most cases, we use 60 to 90 milligrams. 120 is quite high. And you can combine it with acetaminophen. It's completely fine, but I think it's a little bit over the top. We could use that for like larger tumor surgery or something like this. But ibuprofen 200 or 400 milligrams plus acetaminophen is completely fine for the minor oral surgery. It's really completely fine. So which medication would you prescribe in contraindicated patients? I think the author meant patients with certain risk factors such as hypertension, renal or liver disease, diabetes. We already talked about diabetes. Hypertension is indeed a thing for the prescription or recommendation for NSAIDs because due to the effect on the renal system and the blood flow, it risks, or there's a certain risk to higher the or to increase the hypertension of the patients, to increase the blood pressure. For short-term use, it's probably fine, but you have to monitor the patient. Renal disease, already said that. NSAIDs are not really like contraindicated in some cases with very low renal function, but in some cases when it's fine, then you can give like ibuprofen or other NSAIDs for short-term use in low doses, but be careful. The better option would be acetaminophen. And in patients with liver disease, it's the other way around. Here you should, if possible, avoid acetaminophen and go for NSAIDs. So there are some questions concerning completely different subjects. Here is a question regarding the recommendation of antibiotics perioperatively, and I think that's a completely different subject and a very complicated subject in implant surgery, because we do not have a lot of evidence in that. We have some evidence in immediate implant placement in the German guideline, I think from last year. They said if you have some chronic infection at the tooth side and you want to perform immediate implant placement, you should give antibiotics once prior or during surgery. But there is no clear evidence for perioperative antibiotic treatment for every kind of implant surgery or augmentation surgery. In augmentation surgery, there are some studies showing that when you give the antibiotics, the outcome is a little bit better. What we have to be in mind that we have resistances against the antibiotics, a lot of them, and we have to be a little bit careful because there I already explained the number needed to treat. We have a really high number needed to treat, especially when you only place implants and do not perform any augmentation surgery. We have a number needed to treat of 20 to 30 patients you have to treat to avoid one infection. So I'm very sorry, but I do not really understand the last question. So thank you very much for your attention, for your time. And in Germany, it's already evening, so I wish you all a nice evening, nice day, nice morning, whatsoever. Thank you very much.